Good afternoon. Welcome and thanks for joining us for today's HIS Talk webinar, Using Socioeconomic Data, Not Just Demographics, to Create a Healthier Patient Population. It's brought to you by LexisNexis Health Care. I'm Lori from HIS Talk and I'll be moderating. We have two speakers today. First up will be Eric McCulley, Director of Strategic Solutions Consultants at LexisNexis Health Care. Joining Eric will be Aaron Benson. Aaron is the Director of Market Planning also at LexisNexis Health Care. And with that, I'll turn it over to you, Eric.
Great. Thank you, Lori, and hello, everyone. Good afternoon. Aaron and I would like to thank all of you for taking time today to consider some new and innovative strategies in achieving your organization's quality and subsequently financial goals. It is our sincere hope that the information shared with you today will evoke careful thought and facilitate some meaningful follow-up dialogue within your respective healthcare systems. We'd also like to extend our thanks to the HIS Talk professionals for their collective support in facilitating the dissemination of this important content. Specifically, this afternoon, we will delve into two intricately related healthcare topics, the first of which is quality attainment, and the second, social determinants of health data. So let's start with this rapidly changing and evolving healthcare landscape. Namely, this migration of reimbursement structures from a fee-for-service to a fee-for-value framework. I think everyone on the call today understands the basic tenets of this paradigm shift, and perhaps the easiest way to break it apart is by considering the triple aim. So the triple aim really focuses on the simultaneous improvement of the health of the population by enhancing the experience and outcomes of the patient, and at the same time, reducing the per capita cost of care for the benefit of the communities. The triple aim framework serves as the foundation for organizations and communities to successfully navigate the transition from a focus on healthcare to the optimization of health for individuals and for populations. In fact, today, and at several recent conferences this year, there's talk of the quadruple aim. And that really begins to focus on a fourth pillar, which is health equity, or efforts to improve population health outcomes. For some, they suggest the triple aim will always be incomplete without understanding and addressing the unjust distribution of healthcare outcomes relative to the heterogeneity of the patients that comprise their respective health systems. So to secure population health progress for everyone, every family, and the community that we serve, it's important that the interventions are aimed at tackling these disparities and these inequities. Clearly, a better and more holistic view of the patients we serve is a big step towards satisfying all four of these pillars in a well-defined quadruple aim strategy. So this transition to value really is a two-stage process. It's about quality, and it's also about accountability to achieve this triple or quadruple aim. Quality really speaks to and defines the standards and measures that we use to compare and score our progress. Accountability, and we'll speak more about this later in the presentation, really speaks to the evolving shared framework or risk and reward platform between what used to be a fairly siloed healthcare system between the payers and the providers. And so we're really striving towards an everyone wins mentality. And is this even possible? Will plans and health systems effectively work together? There are several quality programs that initiated at the payer level and are beginning to find their way into the operational workflows and framework of the provider healthcare systems, whether they be ACOs or IDNs. One of these ratings is the STAR ratings, and I'm sure most of you are familiar with these ratings. They really speak to how CMS defines important strategic goals to improve the quality of care and the general health status for their Medicare beneficiaries. CMS publishes the Part C and D STAR ratings each year to measure quality in Medicare Advantage and prescription drug plans or Part D plans. And these STAR ratings really measure 5 broad categories of outcomes, intermediate outcomes, patient experience, access, and process, all of which are key components in how providers or integrated health systems are striving towards some of these same quality metrics. One recent development, as announced in the 2017 call letter and detailed in the Medicare Part C and D STAR rating technical notes, is that CMS has implemented an interim analytical adjustment called the Categorical Adjustment Index, or CAI. And this CAI is a factor that is added to or subtracted from a contract's overall or ratings to adjust for the average within contract disparity in performance associated with a contract's percentage of beneficiaries with LIS or low income subsidy dual eligible populations. This is an evolution in how they are benchmarking and measuring success and begins to take in that fourth pillar we talked about earlier, which is health equity. There's no question that these disparities have to come into account when how we're being measured is against populations that can vary so drastically across health systems and even within certain health systems. And lastly is HEDIS. HEDIS is a tool that's developed and maintained by NCQA and used by more than 90% of America's health plans to measure performance on important dimensions of care and service across all lines of business, Medicare, Medicaid, and commercial populations. So consumers also benefit from HEDIS data as it's shared broadly through the State of Health Care Quality Report. And this is a comprehensive look at how health systems are performing and compare against each other. And a big key driver of that is survey data through the CAHPS 5.0, which was released this year. And brand new for 2018 is quality measures that are tied to all-cause readmissions. The Hospital Readmissions Reduction Program, or HHRP, is really pointing directly towards an area where most health systems have historically struggled to maintain quality standards over the years. They've added the Medicaid product line to this all-cause readmissions criteria, and they've replaced all references to average adjusted probability of readmission with expected readmissions rate. This again takes into account the CAI and addresses the fact that the heterogeneity in our patient mixes should be considered when we considered what are the expected readmissions rate. So we'll get more into that later. So what remains at the center of quality attainment through regulatory standardization is, and perhaps will always be, cost. Regardless of whether or not you have a profit versus nonprofit designation, healthcare dollars must be appropriated to deliver care. The questions that most often drive the organizational strategy are predicated on how to achieve the most optimal care at the most optimal price. So a question, are you incentive driven or are you penalty sensitive? Well, I wouldn't be surprised if your response is yes and yes. Consider this observation from John Halmika, the medical doctor and CIO of Beth Israel Deaconess Medical Center in Boston. He said, quote, "The 962 pages of MACRA are so overwhelmingly complex that no mere human will be able to understand them. As a practicing clinician for 30 years, I can honestly say that it's time to leave the profession if we stay on this current trajectory." Well, that was well over a year ago, and like it or not, MACRA is certainly here to stay, and the MIPS and APM programs that support the reimbursement structures for MACRA are certainly evolving and getting more and better developed as we go through 2018, the first full reporting year in this system. Between MIPS and APMs, MACRA is only one reason that your heads might be spinning with this transition from fee-for-service to fee-for-value. There are other new reimbursement drivers with requisite qualifiers that will continue to surface both from public and private payer organizations. So health systems must be analyzing all of these these emerging quality payment programs to understand their exposures as well as their opportunities. While it's difficult to navigate and implement these programs, there are indeed some opportunities for everyone to grow through these improved care process and information sharing platforms that will help set the stage for better engaging patients and ultimately improved value and improved outcomes. So the cost of care delivery must focus on new processes in risk-based or risk-sharing environments that heretofore were not impacting cost or reimbursement structures at all. Additionally, uncompensated care or services may need to include uncompensated resource utilization. Clearly a challenging uphill battle as we look to tackle these new initiatives. Northwell Health CEO Michael Dowling told Becker's Hospital Review a year ago, quote, "We are inundated with a plethora of micro-regulations, and that, I think, just makes the business much more complicated than it needs to be. It consumes excess resources and just doesn't do enough to improve outcomes for patients. This is not to suggest that I'm against compliance, but the constant development of dozens of regulations on an ongoing basis makes the machinery of progress move much more slowly than it could. So while these two physicians and chief executives of their respective organizations have a fairly negative outlook on just how challenging this can be, I hope that through the remainder of the presentation, we can shift that lens a little bit and think about what it's helping us to become. And while it's challenging, I hope the merit on the other side of this equation with respect to quality and payment will indeed make it better for the patients, which are the people that we ultimately serve, either as an industry or a healthcare system. So I think it's important to recognize that reactiveness is no path to financial sustainability. And this general theme will come through the next few talking points in the presentation. We really can no longer expect service-based fee structures, that is, diagnose, treat, and follow up, or wash, rinse, repeat, to be sufficient. Everything within value-based reimbursement requires identifying and managing those that are most likely to present increased costs associated with worsening conditions. As before, the cost of care required strangles the revenue associated with it. This in and of itself isn't really a new concept, but what's new is that reimbursement is more closely tied to this proactive and preventative approach to healthcare, more so really than ever before. And inside of this new path, new staffing roles and new coordination efforts are beginning to emerge. ACOs, patient-centered medical homes, integrated delivery networks, and the like are really creating this opportunity to more proactively seek risk-sharing agreements. And therefore, these organizations must focus on the success or adequacy of their patient engagement strategies. This is critical to manage the overall care coordination required. In fact, just a few months ago, the American Journal of Managed Care published these findings. A survey of clinical leaders at 17 accountable care organizations revealed an evolution in workforce structure. Value-based models have led ACOs to use more interdisciplinary teams, stratify those roles based on patient risk categories, and focus these resources on improving care for those patients that represent the highest risk. They conclude that these ACOs report considerable changes in health workforce roles to meet the aims of value-based payment models, but significant differences between these models do remain. So, due to the need to tailor care models to the needs of the local population, a single model of care is unlikely to emerge. So here are some questions for you to consider. How are you stratifying patient risk today? And in what populations are your priorities? Is it a combination of high cost and high utilizing patients? Or is your priority tied to quality metrics in specific lines of business? Perhaps you've even identified healthcare disparities that are specific to your patient populations based on disease state and demographic data. Regardless, what data do your analytics and care management platforms rely on? I think you have to ask, are you still dependent on outdated and often unreliable encounter data? There is seldom disagreement that delivering the right care to the right patient at the right time is fundamental to the medical community. However, what does become more of a question is whether a traditional diagnose and treat model is even sufficient to achieve and sustain quality. Or do you need to consider other methods of outreach versus just intake? Let's consider these three metrics that align with the triple aim. Quality of health outcomes. Social factors account for 33% of total deaths in the US each year. Social, economic, and environmental factors determine 50% of overall health. These were findings from Kaiser in their county health rankings. Financial risk. At least 25% of healthcare spend treats diseases or disabilities that result from potentially changeable behaviors. This is data published in the American Medical Association. And lastly, patient engagement and retention. Patients less actively involved in their own healthcare have an 8 to 21% higher cost than more actively involved or engaged patients, and are nearly twice as likely to be readmitted within 30 days. And we'll talk more about these phenomenon in just a little while. But given these facts, something beyond the diagnose and treat model is definitely needed. The blunt reality is, when trying to re-engineer a provider business model, sustainability requires proactive engagement with your patients and/or members. And the industry can really no longer react to a patient making an appointment as he or she reacts to whatever symptoms precipitated their call. Social determinants of health are one alternative and potentially even more reliable data source to enable your shift from reactiveness to proactiveness and thereby better financial sustainability. We need to begin to think upstream so we can improve health rather than just improve the problems that were created by our society not investing. These words were said by Dr. Donald Schwartz from the Robert Wood Johnson Foundation. So what is upstream? Well, social determinants of health data and analytics, well positioned upstream in the workflow, can absolutely deliver better proactive insight into who should be engaged and why. A thought process that was more traditionally reserved for payers, but as these models of providers and payers begin to intersect and have an increasing number of shared performance metrics, patients may begin to actually feel that their medical community is truly acting as one. These same upstream analytics can be leveraged downstream to better define how to intervene in order to maximize the quality of the interaction. With that, it is time for our first polling question. Which of the following would you be most interested in knowing about a patient? Likelihood to be readmitted, likelihood to adhere to medications, risk-based on total predicted healthcare costs, or motivation to care for one's own health?
Yeah, so it looks like we're pretty evenly split between the last two options, so risk based on total predicted healthcare costs and motivation to care for one's own health. What are your thoughts on that, Eric?
Yeah, I'm actually not surprised at all. So what we hear often in our engagement with healthcare systems is there is so much disparity in the data that it's very difficult sometimes due to interoperability issues or lagging data. It's difficult to paint a patient profile and stratify the risk and really understand that particular patient. So the total healthcare costs associated in the absence of those types of data would seem to be really important for most. Motivation is also really important. Often the bandwidth of those resources that are deployed to manage their care coordination platforms are thin. And so understanding who is most likely to respond to those interventions can achieve better quality with greater efficiency. So those are absolutely spot on with what we would have expected. Erin, transitioning to you.
Thanks, Eric. I think that gives us a great background on key trends in the market, and I'm glad to see that there's so much interest in using predictive analytics. Social determinants of health, including information on relatives and associates, assets, trends over time, neighborhood and household characteristics, and more, can all be utilized to improve care management and risk stratification activities, just like the ones that we looked at in the poll. And looking at what is occurring in the healthcare market, it's been clear to me that the value of social determinants is becoming more recognized. But defining what data provides insight into those social determinants and how to use it is a lot less clear, I think because it's defined in so many different ways. So in order to shed more light, I wanted to start by separating 5 common myths that we hear about social determinants of health from the truth. The first myth that I hear is that socioeconomic data or social determinants of health data is just more noise in an already data overloaded world. And it's true that in the age of big data, it's easy for payers and providers and care managers to become overwhelmed with the sheer amount and variety of data that's available on their members and patients. But socioeconomic data is just one of those key pieces of data that should rise to the top. As you mentioned before, social, economic, and environmental factors determine 50% of overall health. And what's interesting is medical care actually only determines about 20% of overall health. So it would make sense that to effectively achieve those better health outcomes for patients, providers can't afford to ignore 50% of what determines their patients' overall health. This is backed by the National Quality Forum, the CDC, and the World Health Organization, who have all acknowledged the impact and importance of addressing these social determinants of health. Various studies, as the ones you've mentioned, have also shown the impact that social determinants have on health, including the Kaiser study you'd mentioned that found that 1 in 3 deaths in the US can be accounted to social factors. In addition to being very valuable data, socioeconomic data can actually make patient risk assessment more efficient and less time-consuming. For example, using socioeconomic data can eliminate the need for many of the survey questions and subsequent manual entries that are currently used in patient surveys. This saves staff time and decreases the risk of manual entry errors. This data can also be integrated into EHR and population health systems for easy access when making decisions about care. For hospital systems that are concerned about overwhelming their physicians with data, we're seeing that other medical staff, social workers, or even newly created positions like health coach roles can help assist patients with getting access to community resources instead. The second myth that I hear is that all data about a person and their life outside of their clinical diagnosis relates to their social determinants of health. The truth is that while the data may be useful in some capacity, not all data about a person is actually a social determinant of health. There are endless ways of receiving data on individuals, including basic demographic data, survey data, and other EHR data. But a lot of it has limited potential for improving predictive accuracy or identifying hidden risks. The key to addressing social determinants of health is to identify a source of data that is continually updated, provided in a consistent format based on reliable sources such as public records, and contains data that's been clinically validated to predict healthcare outcomes. Clinically validating attributes is critical to successful predictive analytics because some attributes don't correlate strongly to health outcomes. In an analysis by our data science team of over 560 attributes, only 442 were found to correlate with key health outcomes like readmission, medication adherence, hospitalizations, and overall health costs. Even when attributes are clinically validated, different attributes correlate to different outcomes with different accuracy strengths. So as an example, it's commonly understood that the likelihood of being readmitted to the hospital after a discharge increases with age. What's less known is that you're less likely to be readmitted to the hospital within 30 days after a discharge if you have a higher average property value than other individuals your same age. Knowing correlations like that can help determine which data enhances predictive power so you can improve risk stratification efforts. The third myth of our 5 is that examining only individual socioeconomic attributes about a person will allow you to make accurate predictions about a patient's overall health risk. The truth is, focusing on individual attributes rather than a combined picture can be misleading. It'd be like eating the individual ingredients of a cake and expecting them to taste the same as the cake itself. The results are very different. So in predicting risk and personalizing care management, it's crucial to view a person holistically across multiple categories of social determinants. These can range from social and community context to economic stability and education to neighborhood and built environment and more. Any attribute on its own is simply not enough to develop an accurate risk understanding, but by using a combination of relevant attributes, a more complete picture emerges. For example, low income often correlates with poorer health outcomes because individuals can't pay for their care. But the additional knowledge that that patient is in college may indicate that the low income is temporary. The patient may actually be more likely to attain a better health outcome since education often leads to better career opportunities and a higher future income. Our fourth myth is the one that I probably hear the most often, and that is that aggregated data at the zip code or census level can be used to personalize care for a patient. I think for market expansion and resource allocation decisions, looking at the aggregated level can be very useful. But for personalizing patient care, hundreds of attributes need to be considered when determining an individual's health risk. Within a single zip code, it's not unusual to see variance in income levels, crime rates, and other factors impacting an individual's neighborhood and built environment. You think about a major city like Atlanta, where we are, and the amount of change you see just by walking a few blocks, this becomes obvious. This is why it's important to look at an individual's specific address. Further, focusing on zip code alone ignores the influences of education, economic stability, and social and community context. So going back to my previous analogy, it's one of many ingredients you'd need to bake a cake. Getting data across various categories of social determinants at the individual patient level allows care providers to see that comprehensive view of the patient and create a more comprehensive plan of care outreach. And finally, our fifth of the top 5 is that social determinants of health data is only useful in combination with clinical data. It's true that adding socioeconomic data to clinical data can help providers to personalize care and more accurately predict risk. However, even in the absence of this clinical data, such as with new patients, using only socioeconomic data has proven to be useful. It can more accurately predict risk based on total costs than traditional age-gender predictions alone, and it's shown to be as and sometimes more accurate at predicting readmission likelihoods than certain clinical data models. Even small lifts of 1% or 2% in accuracy over traditional predictions can lead to big impacts. Using socioeconomic scores to more accurately identify higher-risk patients who account for the majority of healthcare costs and proactively addressing their care can lead to 10 to 20% savings over using traditional predictive models alone. The key takeaway from all of this and reviewing all these myths is that socioeconomic data is a vital force for healthcare risk prediction and the improvement of care management. So we'll discuss how that translates to value next.
So earlier in the presentation, we alluded to MACRA and how MACRA's influence is really changing the landscape of healthcare. I wanted to take just a minute and review the payment structures underneath of MACRA as they relate to MIPS and alternative payment models. Whether your organization is heading down the MIPS track or heading down the alternative advanced payment models track, the one common theme across the two is that it's about taking on risk, defining quality, and being rewarded along the journey. And it's really not an option when it comes to managing your CMS lines of business, as these are mandates that are steeped now in the legislature, which is requiring everyone to take these proactive steps. So MIPS, the merit-based incentive payment system, is tracking metrics within MACRA established to help physicians or physician groups earn performance payment adjustments to their Medicare payments. Payments adjusted based on evidence-based and practice-specific quality data. Our alternative payment models involve sharing a little bit more risk, but ultimately can equate to a higher reward. And as one physician earlier stated in the presentation, that this can be incredibly confusing, the resources on cms.gov to help you navigate these resources is really well done. And I encourage you, if you haven't gone to those sites, to help yourself define a clear path, that you go ahead and do so. So within MIPS, there are 271 measures, 168 of them being defined as high priority. Every health system, if you're in the MIPS track, must choose at least 6, and one of those must be tied to the specialty or practice group with which you're attesting. In the absence of a measure that most closely correlates with your specialty, you're encouraged to choose at least one additional outcomes measure. For advanced payment models, there are 9 models today, and there are 2 new models in 2018. Again, more information is available on cms.gov, but as of March 2nd, CMS has announced funding for several healthcare organizations to develop, improve, update, or expand on their MACRA quality payment programs, whether it's MIPS or APM. And I wanted to alert this audience to the fact that that information is available on www.grants.gov. We talked a little bit earlier about readmissions and the healthcare readmissions reduction program. I want to take just a second and talk in a little bit more detail about readmissions and the overarching impact and true cost that readmissions have in the healthcare market today. It is vital that providers improve risk stratification and adapt their care management strategies to personalized care for these most at-risk patients being discharged from the hospital. Under the hospital readmissions reduction program, CMS withholds up to 3% of Medicare reimbursements if hospitals have a higher than expected number of readmissions within 30 days of discharge for the following conditions. Those are chronic lung disease, coronary artery bypass graft or CABG, heart attacks, heart failure, hip and knee replacements, and pneumonia. Again, the nomenclature has changed slightly in 2018 to be higher than the expected number versus the baseline number. And this is important because it takes into account the disparities and the heterogeneity in your respective patient populations. For this year, in 2018, the payment adjustment reflects a non-stratified methodology. CMS will measure your hospital performance in HRRP by calculating excess readmission ratios, or ERRs, for each of the 6 program measures. An ERR is the ratio of predicted to expected readmissions for one of the given measures. Under the non-stratified methodology, measures with 25 or more eligible discharges and an ERR greater than 1 enter the payment adjustment factor formula, which again can be up to 3%. More than half of the hospitals in 2017 reporting year were subject to the full 3% Medicare reimbursement penalty. New in 2019 will be the stratified methodology. Beginning in 2019, hospital performance in HHRP is assessed relative to the performance of hospitals within the same peer group. This is an important differentiation and change that your organization should be considering in 2019. In 2019, hospitals will be stratified into 5 peer groups or quintiles based on the proportion of dual eligible stays. A hospital's dual proportion is the proportion of Medicare fee-for-service and Medicare Advantage stays where the patient was duly eligible for Medicare and a full benefit of Medicaid. The median ERR of hospitals within this peer group is used as the threshold to assess the hospital performance in each of these measures. Erin?
Thanks, Eric. That gives a lot of good information on the cost of readmissions and a lot of the programs that are happening. So I want to tie that to what we're talking about with social determinants of health and look at an example of how predictive analytics based on social determinants can help to address some of these key program quality metrics. So in this scenario that you're seeing, we have 4 male patients that have been admitted to the hospital with heart failure. Studies have shown that the average rate of readmission is 18 to 20% across conditions, but for heart failure, that rate rises to 25%, meaning statistically, at least one of these 4 gentlemen will wind up back in the hospital within 30 days. But when they have the same age, the same gender, and the same condition, who's it likely to be, and how can it be prevented? That's where social determinants come in. A readmission risk score can be applied that predicts the likelihood of each patient to be readmitted to the hospital within 30 days of discharge based on that individual's social determinants of health. The scores shown reflect the probability of each man being readmitted between 0 and 100%, with 100% being the highest possible risk of readmission. So, as you can see here, Tony's the most likely at 78% to be readmitted to the hospital. Alex and Chris also have some social determinants challenges that raise their risk of being readmitted. What this illustrates is that with only age, gender, and medical data on individuals, we may be missing opportunities to intervene before a complication develops or worsens. Social determinants of health provide that view into otherwise hidden risks. Now, understanding each individual's level of risk, we can effectively prioritize resources, having care providers work the list of patients requiring discharge and follow-up care in order based on their predicted risk rather than other measures such as discharge time or unit location. This improves staff productivity and patient outcomes. A readmission score based on social determinants will improve staff productivity and resource allocation, but it doesn't entirely address personalizing care. The reason that social determinants have such an impact on these patients is because care recommendations need to be a good fit for the patient's environment and not just their medical condition. If recommendations won't work within the person's physical environment, aren't affordable or conveniently located, they're provided in a way that's hard for the patient to understand, then they're not going to be effective at improving their health. So if we look at socioeconomic attributes on these individuals, in addition to their score, we start to see social determinants that can be addressed and risk drivers that can be raised to their care teams. So looking at Tony, who has had a significant decrease in income, he sold his house and moved 3 times over the last year. These are all indicators of economic instability. So Tony's care team should be asking questions to determine if Tony has a stable place to recuperate outside of the hospital, and if he may need financial assistance to help with follow-up care. As the highest risk individual, allocating resources to help Tony with his social determinants challenges would likely be a top priority. Our next gentleman is Alex, and he recently moved to a high crime area and doesn't own a vehicle. So if the hospital is located in DC, we could reasonably assume Alex still has access to public transportation and pharmacies. But if the hospital is somewhere like Atlanta, where transportation is more scarce, a care provider may want to discuss transportation, medication, food, or delivery options with Alex because public transportation can be a challenge. Chris is showing moderate risk. He does have someone over the age of 80 living with him, which may indicate that he's providing care support to that individual. So asking Chris questions about his household situation could lead to getting him connected with a support group or finding alternative care for him and his elderly household member while he recuperates. And then finally, we have Greg, who's not showing any significant risk indicators from a social determinants perspective. Best treatment practices for someone with his aging condition may be the most appropriate. So let's look at our next polling question. The question for you all is, do you currently tailor care management and patient outreach based on socioeconomic information? Your options are: we don't at this time, we use patient-reported health information, we source data from a third party, or other. All right, it looks like the majority don't at this time, followed by using patient-reported health information and then source data from a third party. And then several of you are also using other methods. So I think this is in line with what we're seeing in the market, where providers are really starting to figure out what they can do with social determinants and really determine how they can integrate that into their workflows. It's great to see that they're starting to use patient-reported health information, but we also strongly encourage supplementing that with public records data to increase accuracy and to increase the predictive power. So let's look at the benefits of incorporating this into the system, especially as many of you are considering doing it and starting these initiatives. So the benefits to incorporating social determinants of health are extensive. Of course, most importantly to everyone that works in hospital systems is that providers help patients improve their health outcomes. They can do this by more accurately surfacing patients that require action and improving treatments and discharge planning by addressing not only medical conditions, but also the social determinants of health, like we discussed in the example. The next benefit is that providers can also optimize their financial results. As Eric had discussed before, there's a lot of programs today that are impacting those, such as MACRA and the Hospital Readmission Reduction Program. And by addressing social determinants of health, providers can minimize the financial risk shift exposure in new care delivery and payment models and maximize those performance incentive payments by more effectively treating patients. Then, by providing more personalized care, this can lead to better engaged patients and improved patient retention. For example, in a Health Affairs article, it was mentioned that when healthcare organizations assist patients in accessing basic resources, 69% of those patients said they are more likely to recommend their clinic. And then, of course, based on our example, we would point out that social determinants can be used to understand which patients are at greatest risk of readmission, to coordinate follow-up care and prevent those readmissions. So where can you use this in your workflows as you're starting to think about incorporating social determinants of health? In our discussions with providers throughout the year, we're seeing a desire to help patients improve health outcomes throughout the patient journey. So at the beginning, social determinants of health data can act as an early warning system and risk stratification tool to prevent conditions from developing or worsening. Following an admission, social determinants data can positively impact discharge planning and follow-up care to prevent readmissions. It can also be used in predictive modeling and to enhance medical research with the goal of improving care for current and future patients in mind. When you think of your own organizations, where do you envision there being the most value? Let's look at our next poll. The polling question is, do you use any form of health risk score based upon non-clinical data? Yes, we use health scores based on non-clinical data. No, we use health scores based only on clinical data, or no, we're not leveraging any health risk scores at this time. All right, so it looks like the majority are not using any. Those that are primarily using clinical, but we do have some using non-clinical data. I would say that we're seeing a trend where a lot of groups are starting with the clinical scores, and then they do start to incorporate those non-clinical scores. So both can actually add value when you're looking at them, because they look at different aspects of an individual so that you get that holistic picture. So Eric, I will turn it back to you.
Thanks, Erin. So whether organizations create new or utilize existing clinical analytics models, socioeconomic data can in fact be easy to access and even use. Socioeconomic health attributes, as referred to earlier in the presentation, can take on a lot of different perceptions depending upon who you talk to and in what context. At Lexis, we have hundreds of unique patient-level clinically validated socioeconomic attributes that can be combined, as we discussed upstream, as part of your clinical analytics processes to build models and better assess risk for patients with or without claims data. And it can also be used to correlate to specific health outcomes. Part of the clinical validation of those attributes include total cost, hospitalizations, prescription costs, adherence to medications or pharmacy compliance, emergency room visits, stress, and even the motivation to care for one's own health. Socioeconomic health scores, which earlier in the presentation, several of you referenced as being something that you thought might be of value to your organizations, predict the risk of total cost, or the total health care, total score, the total cost of health care for the next 12 months. And the readmission risk score predicts the potential for an individual to be readmitted to the hospital within the next 30 days. Earlier, we worked with an organization that developed wellness plans for large payer systems across the country. And to test our data, they ingested our socioeconomic health score and compared that to what they already knew the claims data revealed over a 12 to 24-month period. To correlate or prove the power of predictive accuracy of our total health score, you'll see in this diagram that the top 10% of cost in the actual claims data was statistically significant and correlative to the top 10% of the actual cost in the population. Perhaps as impressive was that the bottom 10% was also statistically correlated. Again, the ability to take socioeconomic healthcare attributes and risk stratify a population in the absence of any clinical data and directionally correlate costs from the top 10% to the bottom 10% is a pretty impressive feat. One other output from this particular case study was that in the top 10% of risk, the prevalence of chronic disease states was also very closely correlated. In fact, the overall risk among these conditions was directly correlative and statistically significant. Diabetes, cancer, cardiovascular conditions, end-stage renal disease, musculoskeletal conditions, GI conditions, and respiratory. So in the absence of any clinical data, the ability to risk stratify a population based on cost and the directional correlation of chronic diseases can be a wealth of information to help you begin to understand who the population is and how best to approach them in your risk stratification and care management processes. So with deeper insight, case management can become a case study in unrealized potential. We've asked you to consider all of the information that's been disseminated today and to think about your processes and workflows and how you ingest data, how you think about that data, how you build analytics on top of that data to ultimately achieve the triple or quadruple aim. The type of data most commonly used today is clinical data. So I'd ask, are you considering other contributory sources of data, like public records data or other patient identity data, to help you in your risk stratification process upstream or in your intervention process further downstream? And what relevant insights can you take from that data? Keep in mind the points that Aaron shared about the individual ingredients and the entire cake. How do these disparate data points, whether they are social or clinical, work together to create a more comprehensive patient profile? And finally, what analytics can you derive, or what insights can you derive based on these data and these analytics, and how can it help you move your quality initiatives forward? Part of the counsel and consultative service that we provide our customers today is how to think more strategically about the data they ingest and what that data can mean for their overarching quality attainment strategies. It's really important to understand that whatever data is used for the purpose of building predictive models or gleaning additional insights for the purpose of care management, that data should be recent, it should be comprehensive, or paint a broad brush stroke of all of the categorical social determinants of health that Aaron outlined earlier, and also represent longitudinal value. In other words, sometimes it's more important to understand what's happened in the last 6 months, whether that be income fluctuations or name changes, rather than a static variable which could say this person is in a particular income bracket. Housing stability, financial stability, all of those things can give a greater level of insight into what's most appropriate in terms of stratification and care. You also should consider how are these data linked together? With all of these data and all of the sources that contribute, how confident can you be that the identity level information is tied to the right individual? And finally, is that data clinically relevant? I hope you recall that earlier in the presentation, Aaron stressed the importance that data in the absence of clinical validation is nothing more than just a data point. But when it correlates to something meaningful, like hospitalizations, ER visits, or motivation, you can begin to really work that data into the workflows to get the best possible outcome, which ultimately, and at the top of this scale, shows that it can improve your predictive accuracy or provide greater quality attainment than more traditional models or data sources themselves. And with that is our final polling question. Which of these performance metrics does your organization feel can be most impacted by social determinants of health data? Care coordination efficiency, improved health outcomes, increased patient retention, or other? Please take a moment and respond, and we'll review the results in just a moment.
Well, Eric, it looks like overwhelmingly improved health outcomes is the top, but we also got quite a few for care coordination efficiency.
Yeah, and I think that speaks to what the general themes that we've pulled through this presentation are all about. Improving health outcomes should be the #1 goal for most of our healthcare providers. But if those quality ratings are already well established, then efficiencies can also translate into better cost and better utilization of the resources that are had. And we've had some organizations even extrapolate that those efficiencies equate to better satisfaction in the workplace, and that can have a demonstrable impact on patient satisfaction as well. So not surprised at all by the results, but very encouraging that it's consistent with the data that we presented.
I agree.
So we now have time for your questions. Aaron and I are happy to address any questions that you might have.
Thanks, Eric. As a reminder to attendees, please use the questions section on the GoToWebinar panel to submit your questions to Eric and Aaron. Our first question is, how can socio-determinant data be integrated into EHR systems with data alerts that are customizable to patients, treatments, and conditions so that providers can make score-based decisions with greater accuracy and confidence?
That's a great question. So the key with using attributes is to be able to look at a lot of different factors, as we've mentioned previously, and look holistically at the individual to be able to determine different health outcomes. By using that to create different models, you can start to predict things like readmission, medication adherence. You can look at total cost overall, likelihood of being hospitalized, and so forth. And then you can integrate those types of alerts and scores into the EHR systems so that they can be pulled up for providers and other care managers so that they can start to make decisions about prioritizing which patients to address in which order, and also what kind of care they might need. We're even seeing EHR systems starting to build in social determinants of health pages that give them more insight, and then tying those to things like the Uber and Lyft programs that allow you to provide transportation and follow-up care and things like that. So we expect that to continue to be the trend as more and more community-based groups start to get integrated with some of the EHR systems through their services. So it's going to become a bigger and bigger trend.
Can you talk a little bit about the data science behind developing the readmission and socio risk scores you have?
Sure, absolutely. So as we discussed earlier in the presentation, the social determinants of health, or 442 attributes, were all clinically validated against strategic healthcare targets. I'm sure those were all the things that resonated with you as you saw them on the screen. Things like readmissions, things like total cost, things like hospitalizations, emergency room visits, and motivation. When you do your due diligence down in the weeds, so to speak, and validate those attributes, you're creating the building blocks to create accurate and meaningful predictive scores that are predicated solely on those social determinants of health.
All right, well, that was our last question, so it will conclude our webinar. Thank you for joining us today, and thank you, Eric and Aaron, for the interesting and informative presentation. We look forward to seeing you at our next HIS Talk webinar. Enjoy the rest of your day.